The video is intended for education and training of eye surgeon. Viewer discretion is advised, not recommended for children. Hello, I am Dr. Sourabh Patwardhan from Nandadeep Eye Hospital, Sangli, India and FECO Training Center. And in this video, I'll be speaking about a case of black cataract with corneal opacity. This is a 66-year-old male, black cataract, secondary Sjogren syndrome, so severe dry eye and corneal opacity. We have already done punctal occlusion and you can see the black cataract. This patient is one-eyed, so the plan is to do small incision cataract surgery here and then rehabilitate the patient with scleral contact lenses. So tips here is to do minimal cautery, be careful about the thin cornea, cut while coming out. You can just watch my movements of the crescent blade and make a large scleral tunnel of 7 mm length. We don't have to worry about astigmatism here. We want a very safe removal of this big black nucleus. So that's the main aim. So take your time to create the scleral tunnel. Try to avoid buttonholing as the cornea may be thinner. As you can see in this area of vascularization, it may be thinner, so be careful about those areas. I have to stain the capsule. The cataract is jet black and I would like to see if I can have some contrast while I do the capsular rhexis. I am going to use Hylucot combination of 3% hyaluronate and 4% chondroitin sulfate to take care of endothelium. Now these are the three gates for nucleus delivery: anterior capsular opening, pupil and scleral tunnel. So I am using iris hooks to enlarge the pupil. I want to have a very big capsular rhexis here, at least 6.5 mm, and as you can see the contrast is very poor because of the corneal opacity and the black cataract. So I go ahead, I can see the advancing flap. Now this is the area of opacity, so I am going to ask my assistant to just shine some light using the endo illuminator at an oblique angle so we can see some movement of the flap here. As you can see, the bluish flap is visible. Now I come back to the area where the cornea is little clearer, so I shift back to the microscope illumination and I'm going to use the microcapsular rhexis forceps all throughout because I want to catch hold of this flap and then complete the rhexis. Just watch here how I am trying to complete the rhexis. I want it to be as big as possible. So this is done. You can see the large capsular rhexis is achieved in this case, which is a very good thing to have for these black cataracts. So I am going to now enter using 2.8 keratome here, trying to make the inner incision as parallel to the limbus as possible with a generous large scleral tunnel. Minimal hydro. This is a black cataract, so minimal hydro, and I was able to rotate the nucleus here. Now I want to prolapse it out, so one pole has to come out, so I am going to use a long Sinski. This is a 1 mm Sinski, and I am going to go around the equator of this black cataract and nudge it anteriorly. So once you hook it at the equator and pull it up little bit, these nuclei usually come out of the bag. So one pole is already out, and now I am going to use the wire vectis to engage this nucleus. You can see the nucleus got engaged, but the scleral tunnel has to be enlarged a bit because there was some resistance felt. So I am going to use keratome to enlarge this outer incision of the scleral tunnel. As I said, I am not worried about astigmatism here. I want a very safe delivery of this large nucleus. So I have opened the incision little bit, pushed more viscoelastic around the nucleus. This is a big black nucleus, and now I am going to press the posterior lip, and as you can see the nucleus was already engaged in the scleral tunnel, and just little press over the posterior lip and I could get the nucleus out. And I am going to do irrigation aspiration of the cortex using the coaxial, which I am used to, and here we have to be careful about the bag, so I don't want to pull out the bag by mistake, and just take out whatever cortex is left. The cortex removal has to be performed very carefully because of the low visibility, and use low vacuum to take it out. I am going to put a 3-piece hydrophobic IL here because the CCC is very big, so I don't have to worry about whether I am going to place the IL in the bag or in the sulcus, and because of this poor visibility anyway I am not be able to confirm where the haptics are lying, but for this IOL it's okay to lie in the sulcus as well and we should have good outcome. So I am going to remove all the viscoelastic from the anterior chamber here to avoid any post-operative pressure rise. I want to give minimal post-operative medication in this patient, adequate lubricating drops, and once patient recovers from this, we are going to give scleral contact lenses to this patient, which can help in the severe dry eye condition and also improve the visibility. So we hope that patient will get good vision back after rehabilitation with scleral contact lenses. For more such videos, do subscribe to my YouTube channel and do visit our website phacotraining.org.in. Thank you.